Good. And they actually came out with a recommendation that men should not have a PSA test done. Needless to say, this caused a lot of controversy. All of the urology groups have taken a stance against that recommendation, and I'll be talking about that a little bit more in a second. All that has culminated in my professional organization called the American Urological Association to change their guidelines for early detection of prostate cancer and PSA screening, which came out in our latest national meeting in May of 2013, and I'll go over that in a few minutes too. With the PLCO, the LEPA trial, which was just a U.S. trial, over 76,000 men were randomized to two groups. One was a group that had PSA and digital rectal examination testing on a regular yearly basis. The other one was called usual care. Usual care just meant they were not on any regimented screening schedule. They may not have gotten any screening at all, or they may have gotten sporadic screening, but they were not on a set schedule. In this study, they found that 70% more cases of prostate cancer were discovered in the men who underwent annual regimented screening than the control group. However, the big news was that the study showed there was no difference in the two groups in terms of how men died from prostate cancer. There was no difference. The control, or the group that did not undergo regular screening, death rates from prostate cancer were no higher than the screening group. So that set off some alarms. There were many criticisms of this test, or this trial. The main one was that the usual care group, still 52% of them still had a PSA test done, even though they were in the control group. In the screening group, 15% of the men didn't complete annual screenings or digital rectal examination and PSA tests. And also, of the screening group, only 31% of patients who were deemed to undergo a biopsy underwent a biopsy. So there was a lot of criticisms of this trial, but it did show that what we previously thought about the benefits of PSA screening and digital rectal examination may not have been all that we thought it would be. Now, with the European trial, there was some differences found. With the European trial, over 182,000 men were enrolled, and they were randomized to every 4-year PSA test and digital rectal examination, or no screening at all. In that group, 39% more cancers were detected in the screening group than the control group. And in that study, which was higher powered, meaning statistically it was more valid, they detected a reduction of deaths due to prostate cancer by over 20%. So in the European study, they did find that there was a difference. These were the two largest trials to date of PSA screening and digital rectal examination versus no regimented scheduled checkups. As I mentioned, there was a government task force that, before they released this bullet point, this is the same group that released the information about mammograms. A few years ago, they came out and said that mammograms were not useful. You shouldn't get mammograms. There was a huge outcry, and they kind of pulled that recommendation back. That never really went very far. For whatever reason, this might be some differences between women's health and men's health. But this government task force first released in October 2011 their finding that PSA testing and digital rectal examination were not useful. In fact, they went so far as to say that PSA testing can harm men. And the statement was finalized in May of 2012, where they recommended against healthy men undergoing routine screening PSA testing. I think it's important to point out also that this government panel did not include any urologists or oncologists. They were pretty much made up of statisticians, public health officials, and the head of the panel is a pediatrician. Nevertheless, they did not retract the recommendations, but the findings from this panel is not supposed to have any binding effect on Medicare or insurance companies. And at least right now, in September 2013, there hasn't been any change in terms of how insurance companies and Medicare reimburse for these tests. And hopefully it won't have an effect in the future. We'll have to see. The urology groups, the two biggest ones are the American Urological Association and the Large Urology Group Practice Association. Their stance is that PSA testing is only a blood test. It's not harmful. It's not any different than any other blood draw. It's really what do you do with the information from the testing that is of value. Getting a blood test gives you information, and it's probably, in our view, it's up to the doctor and the patient to have a discussion about what to do with that information. Not everybody who has a PSA test that's abnormal needs to have a biopsy, so that point should be understood. We also say that PSA testing, which has been around since the late 1980s, in the PSA era over the last 25 years, death rates for prostate cancer have decreased by 35 to 40%. While there haven't been any studies that directly link 1 to 2, A to B, that is PSA testing, to decreased mortality rates, we in the field think that is pretty evident because people who've been in practice for 40 years know that 30% of men presented in the 70s and 80s with metastatic disease by the time they showed up in your office, because the only test that you had was a finger rectal examination. And that usually caught prostate cancer when it happened too late. Whereas PSA testing will most of the time catch prostate cancer before you can feel anything on a finger examination. Also, 10-year prostate cancer survival rates have gone from 53% to 97%, also owing to the earlier stage of diagnosis. And the other thing is, at present, there is no better standard accepted test for prostate screening, or prostate cancer screening, other than PSA and digital rectal examination. And every other month in the newspaper, I'll see an article about a new gene test or urine test or something for prostate cancer. But these are usually things that are in studies and clinical trials. They're not things that are quite available to everyone yet. And certainly the other question always is, you want the test, but who's going to pay for it? I mean, there's a urine marker test called the PCA3 test, which has a little bit more sensitivity and specificity than the blood PSA test. And sometimes, on occasion, for special cases, we'll run it on people whose PSA testing are equivocable, and they really have some hesitancy about a biopsy. And the biggest challenge is you have to be upfront with them and say, we don't know if your insurance is going to pay for it. Are you willing to take on responsibility? That's a whole other discussion. Okay. And yes, sir.
What is that other test called?
The PCA3 urine test. What that is a test where a man has a prostate massage done, and then he does the first void sample into a cup. And it's a test run on messenger RNA of prostate cancer cells to see if there's an abnormality in there. That test is similar to the PSA test in that it has what's called high sensitivity and low specificity. What that means is when the test is high and abnormal, you don't know if it's cancer or something else, just like with PSA. But when the test is low, just like PSA, chances are good that there's no cancer. So the value in these tests are when the value is low and normal. You can be pretty sure, high confidence level, that there's no cancer. The problem is when it's high, you don't know if there's cancer or no cancer. Sometimes it takes a biopsy to figure out which one of the two.
So they're both information tests?
They're both information. Yeah, as I said earlier, one cannot make a diagnosis of prostate cancer definitively unless you have a prostate biopsy done. The tissue examination under the microscope by the pathologist is the only way to definitively diagnose prostate cancer. It just doesn't come from blood, urine, CT, MRI, ultrasound testing. So The American Urological Association changed their guidelines this year. Prior to this year, for pretty much decades, the guideline recommendation for prostate cancer screening and early detection had been that men above the age of 50 should have a once-a-year PSA test and digital rectal examination. African American men and men with a positive family history of prostate cancer and a sibling father should have an annual PSA test and digital rectal examination starting at age 40. This is kind of the mantra which we've operated by for many, many years. I say African American men because there has been shown to be racial differences with prostate cancer. Men from African American men, their incidence of prostate cancer is the highest, probably about 200 per 100,000. Northern European Caucasian men, it's probably about 140 per 100,000. Japanese, Asian Americans, ancestry, probably it's about 7 per 100,000. So there's definitely racial differences with prostate cancer incidence. Now, in May of this year, the AUA changed their guidelines with all the information that had come out from the various government sources and studies and everything. They came out with more age-specific ranges to try to best
ChokeOuT Cancer.